Welcome to this presentation on leadership in patient safety and quality improvement. This session sets the foundation for understanding how effective leadership drives real change in healthcare systems. Leadership is about creating the environment in which quality and safety become everyone's responsibility. In healthcare, we're working in high-stakes, high-complexity systems. Leadership ensures that those systems are structured to prioritize what matters most: safe, equitable, high-quality care for every patient. Leaders serve as connectors. They align strategy with day-to-day operations, break down silos, and ensure clinical teams are not only engaged, but resourced to participate in improvement. Leadership makes sure quality isn't seen as a separate initiative, but rather integrated into everything we do: how we train, how we measure, and how we learn. Throughout this talk, I'll refer to leadership as both the formal and informal role. Improvement leadership can and should be practiced by anyone, including frontline clinicians. Leadership is about mindset and influence. Let's dive deeper into why leadership is essential. Healthcare is complex, and no one team can solve safety problems in isolation. That's where leadership comes in. Not to do the work alone, but to unify teams around a common purpose and to ensure that every person, process, and resource is aligned to deliver safe, high-quality care. Leadership sets the tone for the organization. When leaders consistently talk about quality and safety, it sends a powerful signal. That signal helps embed quality into the organizational culture. Effective leaders also make it safe to speak up. When staff feel psychologically safe, they're more likely to report concerns, suggest improvements, and admit when something didn't go as planned. That creates opportunities to learn and improve. Finally, leadership plays a critical role in resourcing improvement. You can't ask people to improve without giving them the tools, data, training, and time to do so. Leaders advocate for those resources and hold teams accountable by setting clear goals and following up on progress. Let's break down what quality leadership actually looks like in action. These 4 domains, vision, empowerment, data, and learning systems, form the foundation for how leaders create a high-performing environment. First, strategic vision. This is about knowing what matters most and helping others see it too. Leaders identify priorities that are most meaningful and measurable, such as reducing sepsis mortality or improving care transitions, and make sure that these priorities are visible throughout the organization. Second, team empowerment. Leaders foster engagement at every level. That means building multidisciplinary teams, encouraging shared governance, and making it safe for people to contribute ideas and identify risks. Third, data-driven decision-making. Leaders help teams access timely, trustworthy, and actionable information. More importantly, they help translate data into insight and insight into action. This includes stratifying data to assess equity across patient populations. Finally, learning and accountability systems. Leaders ensure that there are mechanisms to learn from adverse events, near misses, and variation, such as root cause analysis, morbidity and mortality reviews, and performance feedback loops. Each of these domains reinforces the others. Vision clarifies purpose, empowerment drives engagement, data guides decisions, and learning sustains progress. Leadership weaves them together. Culture is arguably the most important determinant of safety, and it begins with leadership. It's that lived experience of staff, how they're treated, and when they raise concerns, how errors are addressed, and how learning is supported. Let's talk about psychological safety. This means team members feel confident they won't be humiliated or punished for speaking up about questions, concerns, or mistakes. A just culture builds on this by distinguishing types of behaviors. It recognizes that human error is inevitable and often linked to systems, not character. At-risk behavior might reflect drift or misperception, and reckless behavior involves conscious disregard for safety. Leaders who understand this focus on appropriate responses and system learning. The quadruple aim provides a comprehensive framework for healthcare transformation. It's an evolution of the triple aim expanded to recognize the importance of clinician well-being. Why does this matter for leaders? Because improvement efforts often involve trade-offs. For example, reducing length of stay may help lower cost and improve flow, but if done without input from staff, it may lead to increased burnout or reduced care quality. Similarly, pursuing efficiency can't come at the cost of patient-centeredness. Leadership means navigating those trade-offs wisely. It means involving patients and staff in co-designing solutions. It means asking not only, does this improve our metrics, but also, is this sustainable for our workforce, and does this improve outcomes for all patients? Leaders also use the quadruple aim as a compass and are more likely to implement changes that truly improve the system. Let's apply what we've discussed so far in a practical example. In this case, an emergency department noticed an increase in falls among their older adult population. Leadership initiated a structured quality improvement process. First, they convened a multidisciplinary team, including nurses, techs, physicians, and quality experts. This ensured that all perspectives were included, especially those closest to the patient experience. They conducted a root cause analysis, which revealed issues such as infrequent rounding, unclear signage for mobility assistance, and inconsistent communication during handoffs. Leadership supported the team in creating new solutions using the Plan, Do, Study, Act, or PDSA cycles, like improving mobility signage, scheduling purposeful rounding, and redesigning the room layout. More importantly, they didn't stop after one test. They iterated, scaled, and shared the results transparently. Staff were kept informed, and positive outcomes were recognized, building trust and reinforcing the safety culture. This case illustrates how leadership fosters engagement, drives system learning, and supports structured, sustained improvement. High reliability organizations, or HROs, are entities that function in high-risk environments but maintain a consistently excellent safety record. Let's break down the 5 HRO principles. Preoccupation with failure. Leaders constantly ask, what could go wrong? They view every near miss as a valuable learning opportunity. Reluctance to simplify. Instead of defaulting to easy answers, HRO leaders seek deeper understanding of complex systems and the nuanced causes of error. Sensitivity to operations. Leaders stay connected to the front line, understanding workflows and listening to concerns as they emerge. Commitment to resilience. Mistakes happen, but resilient systems bounce back quickly, minimizing harm and supporting recovery. Deference to expertise. In a crisis, the person with the most relevant knowledge takes the lead. HROs empower frontline staff to speak up and act. As leaders, we need to model these behaviors, embed them in how teams function, and build processes that make reliability the default. That includes real-time huddles, proactive risk assessment, robust training, and responsive escalation pathways. Benchmarking allows organizations to compare performance against defined strategies and standards, both internally and externally, and use that information to guide improvement. Done well, benchmarking helps identify variation, promote equity, and prioritize interventions that matter the most. For example, internal benchmarks might compare your ED's left without being seen rate over time. External benchmarks from CMS, NSQIP, or Leapfrog, for example, let you understand how your hospital performs relative to peers or national targets. But benchmarking is more than data collection. It's about what you do with the data. Leadership ensures that the metrics are valid and meaningful, the comparisons are appropriate and balanced, and the results are shared in a way that promotes improvement. As a leader, you use benchmarking to track the impact of interventions over time, align improvement goals with system strategy, and celebrate them when teams close performance gaps. Quality infrastructure is the framework that enables improvement to be more than sporadic or reactive. It gives teams the tools, support, and structure they need to carry out meaningful, sustainable change. Let's walk through a few key elements. QI governance might include an institutional QI committee with representation from departments, nursing, administration, and IT. These teams help prioritize projects, allocate resources, and oversee progress. Dashboard and data access are critical. Teams need timely, accurate, and user-friendly metrics. Reporting systems should allow for an escalation of safety concerns with clear accountability and follow-up. And these efforts must align with operational strategy. Empowering frontline teams is one of the most powerful ways leaders can drive real, lasting change. The people closest to the work, nurses, techs, physicians, unit coordinators, often have the clearest views of safety risks and the most practical ideas for improvement. And they need time, structure, and leadership support to contribute meaningfully. That starts with protected time. When staff are expected to do QI work on top of their clinical responsibilities without adjustments, it can create stress and burnout. Leaders can partner with managers to allocate meaningful time for frontline involvement. Staff should also be involved in every stage of improvement, help identify problems, design and test solutions, and evaluate success. That's where tools like PDSA cycles and frontline huddles are key. Recognition matters too. Leaders should highlight staff contributions during safety rounds, newsletters, or evaluations. That reinforces a culture of shared ownership. And finally, build capability, offering training in QI tools, team facilitation, and data interpretation. No quality improvement effort is immune to barriers, and how leadership addresses them often determines success or failure. Let's start with change fatigue. In healthcare, change is constant. If teams feel they're being asked to do more without clarity, support, or feedback, it leads to disengagement. Leaders can prevent this by sequencing improvements thoughtfully, communicating the why, and involving teams early in design. Burnout is another major threat. If QI initiatives are perceived as burdensome or disconnected from clinical realities, they're likely to fail. Effective leaders address this head-on by aligning improvement work with what staff already value: better outcomes, smoother workflows, and meaningful patient interactions. Data challenges are also common, whether it's too much data, not enough actionable insight, or difficulty accessing what's needed. Leaders must partner with informatics and analytics teams to ensure the right metrics are available, understood, and aligned with the team's goals. Let's take a step back and reflect on the core role of a leader in quality improvement. First and foremost, leaders are visionaries. They help others see what's possible, even when change seems difficult. They connect daily clinical work to broader outcomes and inspire people to participate in the journey. But leaders are also facilitators. They connect the right people, ask the right questions, and remove roadblocks that slow teams down. Role modeling is essential. Leaders demonstrate what matters through their actions. If safety, transparency, or learning are priorities, that must be reflected in how leaders speak, behave, and respond. Great leaders are also listeners. They seek feedback, not just formally, but through informal rounding, anonymous surveys, and more. They adapt based on what they learn, and they communicate that clearly to staff. Finally, leadership in quality is about shared ownership. It's about creating conditions where everyone takes pride and responsibility for improvement. This concludes our overview of leadership in patient safety and quality improvement. We've talked about the essential leadership roles in vision setting, culture building, strategic alignment, empowerment, and sustainability. Every topic you'll explore in quality and patient safety rests on this foundation. Leadership connects all of it. It ensures that improvement efforts are not only launched, but sustained and scaled. It fosters the relationship, accountability, and momentum needed to move from intention to impact. Thank you.